Good morning, good afternoon, good evening. Welcome to this European Microfinance Week plenary on inclusive finance and health. I'm Gabriela Erice from e-MFP, and I'm delighted to be moderating this session. Inclusive finance and health is the topic of the European Microfinance Award 2021. The award is an annual global prize which attracts applications from organizations active in financial services around the world who are innovating in a particular area of financial inclusion. In this year's edition, the award is shining a spotlight on organizations that are facilitating access to quality and affordable healthcare among vulnerable populations. At e-MFP, we are extremely proud to co-organize the award with the Luxembourg Ministry of Foreign and European Affairs, Directorate for Development Cooperation and Humanitarian Affairs, and with the Inclusive Finance Network Luxembourg. The award has two aims. On the one hand, it rewards excellence with a €100,000 prize for the winner and €10,000 prize for the two runner-ups. I invite you all to join the award ceremony tomorrow at 12 p.m. CET, where the winners selected by the high jury will be announced. The ceremony is organized by Infine, and you can find all the details in the dedicated section of the conference agenda. The award also aims to play an inspirational role through the collection and dissemination of the most relevant practices for replication by other sector players. This is an objective that is very close to e-MFP's heart and mission, and it is my great pleasure to launch today the publication for this year's edition, entitled The First Wealth is Health. Authored by my colleague Sam Mendelsohn, this publication gathers the practices and factors for success identified throughout the selection process and features the top 10 applicants. I also invite you tomorrow to attend a session in which my colleague Sam will delve into all the details of this publication and discuss with sector experts that have participated in this year's award selection process. Today, in this plenary, I'm honored to have with me the three finalists of the European Microfinance Award 2021. Crecer IFD from Bolivia, Dreamloments from Thailand, and Foncose from IT. I'd like to highlight that reaching the finalist stage is already a great achievement. We initially received 43 applications, and to be award finalists, these three organizations have succeeded in 3 consecutive selection committees. I have run the award for 8 years, and I can tell you that this year's process was very tough. The relevance and quality of the programs that applied was outstanding. And I'd like to take this opportunity to thank all the applicants for their efforts to apply, as well as for the excellent work they are doing. And also to thank all the members of the different selection committees. I know some of you are with us watching this plenary. Welcome also. And a big thank you, because without your work and commitment, it wouldn't be possible for us to run such a successful award. For more details on the selection process, check the publication. Everything is explained there. And without further delay, I'd like to welcome my fellow panelists, and I'm very happy to have here today Vivian Romero, Vice President of the Board of Directors of Crecer IFD in Bolivia, Nicolas Dourier, Founder and General Director of Dreamloments Social Enterprise in Thailand, and Karin Ronen, the Executive Director of Foncose Foundation in IT. We also have with us today Nicole Warneri, who is one of the consultants that has worked with e-MFP supporting the entire award selection process. Welcome to the 4 of you. It's really my pleasure to have you here and share this plenary with you. Nicole, let's start with you, because you've been supporting the selection process. You've been working on 8 months on this award. You have attended all the selection committees. And I'd like to ask you to help us set a broader context, no? to learn about what you have learned on these 8 months working on the award. And my first question to you will be on the needs. Which needs have been identified when it comes, when we are speaking about vulnerable populations having access to healthcare services? If you can tell us a bit what we have found out, the floor is yours. Thank you.
Going through the 40 application, we have been several needs, but I can maybe identify three and group them in three kind of needs. On one side, the poor needs access to affordable and quality healthcare. Second, they need financial support, and third, they need information. Let me go through them a bit more. So, poor people need access to quality healthcare. They face enormous barriers, structural barriers and cultural barriers. In developing countries, also, often there is a lack of health infrastructure. The geographical distance can be real barriers for example, rural communities. So there are a lot of healthcare needs, and these follow a continuum from day-to-day care, like maintenance care for vaccines or for having drugs for treating the most common health, malaria, digestive disorders, or influenza, to more inpatient treatment and care to face the most serious disease or chronic disease like diabetes, hypertension. Then they can have a serious accident, for example. So the needs are several, and also there are specific targets with specific needs. For example, women that being the childbearer have also additional needs. Then they need financial support. They need the ability to pay for healthcare, because poor people demand protection against the financial consequence of the illness. And these represent a big threat for their income generation capacity. And financing and smoothing the health expenditure is really one of the reasons why clients borrow from microfinance institutions. So this can also be seen looking at some estimate from the World Health Organization that is mentioning that, for example, more than 200 million people will be spending more than 25% of the household budget in facing health expenses, and 1 million people will be pushed back into poverty as a result of unmanageable health expenses. So financial support is needed. And last but not least, information. They need to increase awareness on how they can access healthcare service and the preventive measure in place, because good information can really avoid a small and simple illness to become and go to the serious stage.
Thank you, Nicole. That was very clear, and indeed, this is all what we've seen. How have we seen the applicants serving or responding to these needs, please?
Okay, we have seen that the financial inclusion sector have a big role to play, because he has a role to play in helping the day-to-day plan of the health expenditure, and also we have said financing and smoothing these possible financial shocks. So first role they have is offering appropriate and nice and well-designed financial products. We have seen, the more that we have seen in going through the application are insurance example and loans example. There was also few specific savings or some vouchers or prepaid services, but the focus, the most that we have seen, was insurance and loan. Insurance, almost always, we have an exception with one of our finalists, is facilitated through the partnership with big insurance companies, but can be really very different. We have seen model covering only hospitalization, other covering chronic disease, or other with a broader coverage also for more generic health expenses. Also in terms of payment model, we have seen very different approach in the application, from direct reimbursement, so cashless insurance, to insurance model that just reimburse when the expenses occurred, or other that pay a fixed amount like, for example, a fixed amount for every night of hospitalization. Many different and interesting models. In terms of loans, we have seen some specific loans. A couple of institutions were offering, for example, maternity loans to cover the pregnancy cost and the drugs and all the screening needed. But also, in some cases, some more generic loan for which there was an immediate disbursement in case of medical emergencies to cover medical expense, medical consultation, etc. Beyond this, the financial sector provider have also, having this strong and high-touch relation with the client base, they also have an invaluable opportunities to give access to healthcare. And we have seen a lot of non-financial service also offered to the different applicants. Like, for example, discounted consultation. The institution put in place partnership with care provider and facilitate the access to the clients, or institution directly offering through their own team of doctors and their own clinics, or other activities like awareness raising or advice on good practice to prevent for preventive measure through health camps or through social media campaign or meetings. But let me say that we have noticed that most of the applicants and they have combined both this approach, the financial service and the non-financial one.
It's true, Nicole. This combination, actually, it was quite impressive, no? Don't you agree that this year the predominance of non-financial services compared to other years of the award, you've been involved in the past also, so very impressive how important non-financial services, the role they play compared to other years when the financial services were much more predominant.
Yeah, it's true.
Yeah. So maybe just to close these two questions, I'd like to add just briefly that actually the publication we are launching today, in its sum, is describing 3 approaches to facilitating access to affordable healthcare that have emerged from the selection process, and it's a classification according to the needs being served and the services that are being offered. And we have a first section on preventing and treating illness to avoid them becoming very serious or even causing death, and avoiding the financial shock this will create. And here we have the example of Crecer that you will learn more in a few minutes. Then we have a second section of mitigating the risk of health shocks, mainly a section on health insurance. And you will see with Dreamlomeds is featured in this section, and it's a great example of this. And a third section of delivering healthcare to those who need it most, a section that focuses on innovations in healthcare access and delivery, and Foncose is one of the examples that is featured in this section. Nicole, last question to you before we move on and start learning about the finalist programs. You have evaluated all the applications. You have been in all the committees. What would you say are the main factors for success, or the main factors to be taken into account when developing a healthcare access program?
Difficult question. So there are, I think, several factors, and also it depends on the kind of intervention. For example, we have seen that in insurance program, the fact to offer very simplified claiming procedure and affordable price is really making the program successful. But more in general, I would say that there are 2 main factors of success. On one side is effective product design and investing in the product design phase, because we have seen almost all the semi-finalists and finalists, they have they have invested a lot in that phase, because there is no one kind of intervention that fit all needs. It's really important to study the context and the healthcare needs of the specific target population. So all the finalists, for example, have extensive research with piloting phase and adequacy, and also investing in procedure and staff training. Another factors that I would like to identify is the capacity of the institution to ensuring the quality of the intervention and of the healthcare provision, because the delivery of service with a high quality is a very important point to stimulate the demand in the long run, in the medium and long run. And poor people need and want to get value for money. So this goes generally in the application, at least we have seen, through many partnership with quality provider in the public and the private sector, but also goes through the putting in place system to monitor the quality of the delivery and engaging with the clients to be able to assess the quality as well. So probably the panelists will identify other factors, but I think these are two crucial aspects.
Thanks, Nicole. Yeah, these aspects are actually included in the final section of the publication, where Sam also has identified several factors, and you will find all of them there. But I wanted to have your opinion, Nicole. So thank you very much.
Thank you to you.
Now, okay, let's start now with the finalists. I would like you, Nicole, to briefly present the three of them, the programs that they are doing on facilitating access to healthcare. And maybe, if you want, shall we start with Crecer in Bolivia, please?
Yeah. So Crecer is a non-bank financial institution created in 1999 in Bolivia to reach women in rural communities through village banking methodologies. In Bolivia, the cervical cancer is the leading cause of death among young women, and those deaths could be often avoided thanks to preventive screening and treatment. So in this context, in 2013, Crecer decided to launch the CACU program, that with the main objective to develop the capacity of the women to do auto-diagnostic and preventive care. The program always starts with health camps, where the client can, on one side, receive information on how to prevent the cervical cancer, and on the other, they are offered screening tests at a very discounted price. The program is really very well designed and has embedded strategic partnership with both public and private healthcare providers, and with the Bolivian Ministry of Health. Staff is comprehensively training. There are extensive education module and very nice manual with key messages developed by professionals to ensure that the client receive the proper education and information. So far, 70,000 women have been reached, and 30% of them are under 25 years old. The program at a certain point was extended also to the community and to the family of the members, not only to the client. So a very interesting program. And what I like really the most about this program is the strong gender focus. It's really a program that is designed to meet the specific needs of women in the Bolivian context. So great example.
Great, thank you, Nicole. Now let's move to Thailand and the border with Myanmar, and let us learn about developments, please.
Okay, so we go to Thailand. It's a non-profit and social enterprises that was registered in 2015. Thailand is a primary country of destination for more than 3 million migrant workers that come mainly from Myanmar. And the initiative presented is M Fund, Migrant Fund. is a fund offering low-cost and not-for-profit microinsurance to unregistered migrants in Thailand, and also since 2019 has been replicated in Myanmar on the border in some rural communities. It's an amazing program where there is a team of full employed community workers that are deployed in the project area to enroll the interested client via a secure web-based application. The service the client can access the health service thanks to the M-Fund network of hospitals. There are 28 health facilities, including 2 NGO clinics. What is very good is that the services are available in different language, Burmese, Thai, Khmer, so really customized service. And the fund directly covers the cost, so the client does not have to disburse advance money up to the plan coverage. There are many different plans, from the base plan to the plan for students, the school plan, the plan for chronic disease, for seniors, for pregnant women, so a lot of options. So far, almost 25,000 clients have been reached with these services, and they are mostly women in rural communities. And what I like the most about these other finalists is the capacity of this program to really reach an untapped market and a really excluded and marginalized people that are the illegal, unregistered migrant workers that would not have any other option to receive health protection. So another great finalist.
Indeed, yeah. So I said tough selection process, and the high jury has a tough task now. Okay, Nicole, let's go with our third finalist, Foncose in IT, please.
Yeah, Foncose is a family of 3 companies. There is the Microcredit Institution company, the sister non-profit company, and then there is Foncose USA, that is the communication and capacity building wing. IT, we all know, is a very difficult and tough contest where the rate of mortality of children under 5 years is still very high. So in this context, and looking at that almost 16% of the clients were leaving because of health shocks, Foncose decided to launch in 2014 franchising initiatives, so-called boutique santé, to bring over-the-counter medicament and health products, education, and healthcare service to rural Haiti. Foncose has a dedicated specialized team that is composed by doctor and public health experts who train a team of registered nurses that in turn train some selected clients that generally are the chief of the microcredit centers, and to become community health entrepreneurs. Those entrepreneurs are all women and conduct basic health screening for other members in the community, for example, on malnutrition, on therapeutic feeding, or on pregnancy-related issues, as well as deliver health education and procure and sell health products and drugs. So in 2020, more than 80,000 malnutrition screening were conducted, and 37,000 clients were trained about health education. It's an amazing program with a digital platform to support the implementation. There is a lot of boutique santé branded material provided to the entrepreneurs to do promotion. And one of the most important things, they have a very good and well-established quality control and monitoring that is critical when you want to train people that in the community that are not made expert to train other people and to provide healthcare to others. So This is great and is done by the team of nurses that go and do also monthly unannounced visit so that they can keep coaching the entrepreneurs and also collect feedback from clients. What I like the most about this last finalist is apart being a very replicable and nice healthcare initiative, it also is a business opportunity for the community. And indeed, Foncose also offer a business development loan that can be used for the community health entrepreneurs to build the inventory and be able then to sell the drugs in the community. So another very nice. We don't know who will win, but the three of them are great.
Well, Nicole, thank you very much. I'm very happy you were able to join us for this plenary. And actually, it's kind, as we would say in Spanish, la guinda del pastel, after 8 months working together. So thank you very much.
Thank you to you. It was nice.
And I'd like now to invite the finalists on stage. So Vivian, Nicolas, and Karine, I'm very happy to have you here. So I don't see yet Nicolas and Karine, and maybe, yeah, okay, now I see you, the three. Well, welcome to this plenary. Congratulations again. I don't know how many times I've told you congratulations, but as I said, this is really a great step, reaching this final stage. And I'm very happy to be here with you today. And let's go into the questions I have for you. I'm sure our audience is willing to learn more about your programs. And to our audience, if you would like to ask any questions to our finalists, please don't hesitate to post them on the chat, and we will handle them either through the discussion or at the end. We have some time allowed for that. So, okay, I think I'm going to start with the first question is why you do what you do, no? Why are you facilitating access to healthcare? And maybe we'll start first with Vivian and Karine, because you are both FSPs, financial services providers, that you have decided to actually go beyond just providing financial services and actually helping your clients with these healthcare needs. So maybe Vivian, would you like to go first? Why Crecer is dealing with, is having this CACU program to deal with cervix cancer prevention, please?
Yes, thank you, Gabriel. And hello, everybody. I am honored to be here on behalf of Crecer. CACU is the Spanish acronym of cervical uterine cancer, and CACU is the leading cause of death among adult women in Bolivia. Bolivia also shows the highest death rate in Latin America, as Nicole already said. This key health issue and the historical failures of the public health system are still significant in Bolivia. So, prevention can substantially mitigate this outcome. This is our first why. Our second, our mission mandates the provision of financial and non-financial services to improve the quality of life of our clients, mostly women. The question is why Crecer selected CACU as its main non-financial intervention. We wanted to find an intervention that addresses a critical issue in a cost-effective manner and to focus our efforts on that problem for maximum impact. Health has multiple dimensions and women have multiple health needs. It is tempting to try to solve most of them, but with limited resources, the benefits in each case will be very small. So, we focus on CACU as a significant intervention with a strong feasibility in addressing critical barriers women face. Because of this focused approach from 2014 to 2019, we saw a fourfold increase in our screening indicators from 10 to 40% of our women clients being screened. This is a great achievement compared to the government program, which has reached 10% of the target population during this same period. So these are our whys, Gabriela.
Thank you, Vivian. Now I'd like to ask Karin to tell us phone causes whys.
Thank you, Gabriela, and hello, everybody. Really glad to be part of this wonderful event today from Port-au-Prince. As Nicole was saying, we have evidence that around 14 to 16% of the clients of our microfinance institution can't keep their loans running or can't reimburse their loans because of health-related expenses. Either it is because they are sick themselves, or a child is sick, or a spouse, and they have to invest the capital they use for their business in health-related expenses and get decapitalized like that. So that was the first reason. The second reason is actually that the clients themselves asked us for help to deal with health-related expenses. We regularly have meetings with clients during general assemblies or during more regional meetings with the leaders amongst the clients. And they often tell us about the impact of health-related issues on their businesses. And we're asking Foncose for quite a while for support to help address these issues. So back to you, Gabriela. That's it for now.
Thank you. I was muted. Thank you, Karin. Now, Nicolas, you have a bit of a different profile because you're actually a doctor, a medical doctor, and you've been working for 20 years in humanitarian aid and infectious diseases research programs. What made you, why did you decide to set up an insurance fund like MFund?
Thank you, Gabriela, and hello, everybody. So first, I'd like to say that we didn't start as a microfinance institution providing microfinance services. No, the MFund was started in the outset as a micro health insurance. And it came about from a slow realization of a great need for this model. And it all started when I did, as a consultant, an evaluation of an NGO program offering free healthcare services for unregistered migrants along the Thai-Myanmar border. That program was entirely funded by donors in a context where donor support was decreasing. And in that evaluation, we had to discuss the outlook for sustainability. And I was familiar with the concept of community-based health insurance in other contexts and raised the idea of whether or not this could be applicable for these very specific marginalized population of unregistered migrants. And we did first actually a survey among migrants to check what was the interest and understanding. And to our surprise, actually, we found a very strong interest for this concept, so strong that eventually we jumped and decided to do an entire feasibility assessment of this concept with multiple components, concluded at the end of this that it was probably feasible. We designed the product, the whole program, and launched it in 2017, and we've been running it since that time. Thank you.
And here you are. It's great. Okay, thank you to the three of you. I think it's something what Nicole has said it, and something that it's quite outstanding of your three programs is the vulnerable populations you are serving. So women, unregistered migrants, even very rural populations. So I know your programs have plenty of characteristics and they are very, very complete. But may I ask you to please share the two characteristics that you feel are crucial to be able to serve the populations you are serving. And I'm going to go here in alphabetical order. So I'm going to start with Crecer. Please, Vivian, tell us those two characteristics.
Thank you. At Crecer, the CARCO intervention is mostly a prevention approach. We have identified key barriers that women face in the access of affordable prevention and treatment. And these barriers include lack of knowledge about how serious the illness is, what kinds of screening are available, where women can find a provider of the screening, and what to do if the test gives an abnormal result. The barriers also include women's lack of trust in formal institutions, their fears and their feelings of shame. Also, they tend to think that it will not happen to me. Other barriers include the cost of screening and treatment and the huge opportunity cost in visiting government clinics. CRECER has a comprehensive approach to address as many barriers as possible. The program delivers information, sensibilization, and education by taking advantage of the village banking meetings. It engages the loan officers in the field, while a small team of non-financial specialists supports the development of materials, the staff training, management of partnerships, and data analysis. We have no staff training in healthcare. To reduce costs, CRECER implements regional campaigns for remote areas and has agreements with a network of public and private health providers. They offer discounts for screening and treatment, preferential timeline appointments, and warm and respectful services. Trust issues are addressed through the constant contact with the loan officer and the support among the peers in the group. When treatment is necessary, CRECER offers a health loan product to smooth the expenses for the household.
Great. Thank you, Vivian. Dreamlogments, your two crucial characteristics, please, with Nicolas.
Right, Gabriela. So for us, two key characteristics of the project would be first, peer-led, community-based enrollment of the members, and the second one is use of digital application. Mm-hmm. So with the first component, so we have a team of community workers who do enrollment and renewal of the members. These are all from migrant communities themselves. They speak the language of their peers. They know these communities. They are entrusted by their peers, and they conduct community-based enrollment and renewal where they go themselves to the houses or the workplace of their peers for information, for enrollment and for renewal. And the second component is use of digital application where each community worker use actually a tablet or a smartphone and the secured mFund application that we have designed, and use that for all processes, for registration of the member, capture of their information, for collection of payment, for creation of the plan, selection of the option. And that application is then used throughout the whole system. It is used by partner organizations, partner facilities to identify members, to observe their coverage status, their benefits, and it's then used by us to monitor through the dashboard and the whole range of indicators, real-time indicators and information about the program. So these are two key characteristics that we believe make it success.
Sure. Great. Thank you, Nicolas. Karin, can you tell us about Boutique Sante crucial characteristics, please?
Okay, thank you, Gabriela. Focus Financial Services provides savings and credit and transfer services through 45 branches and 300 credit agents and over 2,000 credit centers, really reaching the whole country. The majority of the clients live in rural areas and 95% of them are women. We regularly, every year, we measure the level of poverty of incoming clients. And we know that 48% of Focus Financial Services clients, credit clients, live on less than $2.5 a day. And 15% actually live on less than $1 a day. So the very first reason why Boutique Santé reaches vulnerable populations is that Foncosé Financial Services reaches really vulnerable populations, and that we can piggyback on their infrastructure, on their microfinance infrastructure, to reach these populations with health services. The second reason why we can reach vulnerable population are the CHEs. The CHEs are the community health entrepreneurs we work with. And they're all women. Today we work with 959 of them. And they're really very proud of being able to take trainings and replicate them with their credit centers and with their communities, providing screening services for hypertension and for malnutrition. Also, they're very proud of the products they sell, both the health, the hygiene, and the nutrition programs. These women we work with are real leaders in their communities. And so they're really effective at reaching populations that traditional health services have more difficulties reaching. And they're really good at providing counseling and referral services. So those are the two reasons. First, it's the microfinance infrastructure reaching rural communities. The second reason is we work with women leaders who are really health resources in their communities.
Thank you, Karin. I think actually both in FONCOS and Dream Developments, community involvement is a characteristic that is quite outstanding in your programs, but I know both of you have, or your institutions have different approaches to this community involvement. Maybe, Nicolas, can you explain us a bit more how you work with the community workers and the community relays? And then, Karin, you can tell us a bit more about the CHEs and how you engage with them. Nicolas, you go first.
Yes, Gabriela. So it's really peer-led, community-based. Then we have two types of workforce or human assets, if I may, for this. So first is the community workers. And the community workers are full-time staff employed by Dream Developments. They are community workers of the M Fund. They are full-time employee, paid with salary and with benefits. But then we have also community relays, and we identified the need to have those community relays. And typically, these are actually often members of the M Fund themselves who have been really quite vocal in promoting the project. And then they become community relays, and in their own communities, they provide information about the M Fund, and they themselves eventually do enrollment and renewal of the M Fund with their smartphone and on using the M Fund application. And the model for incentivizing them is actually to provide commission, actually a significant commission that has been motivating for them and provides actually an income for them as well. So this is the model we use: community workers and community relays.
Thank you. Karin, how do you do with the CHEs?
Okay, so for us, it's a bit of a similar two-tiered system, but we have nurses who are in the branches and who work with the CHEs, the community health entrepreneurs who are in the communities. And the community health entrepreneurs, they're volunteers. So these women, they have a household to manage. They have their own business as Foncosé clients to manage. And on top of that, they accept and they volunteer to become a health resource in their community. So for us, it's always a very delicate balance, making sure that they remain engaged and that we ask them enough to make it interesting for them, but not too much so that they become overburdened and overwhelmed with too much work. To give you an example, they will do 1 or 2 malnutrition screenings in their communities per year, and then follow up with 10 or 15 malnourished children per year again. So it's not a very heavy workload, but they are very proud of the trainings they get, and they're very happy to replicate these trainings with other people in their community. And they're also incentivized by the margin, by the little additional revenue they make when they buy and sell the health products we sell them.
Great. Thank you. I think it's very interesting to see different approaches on how to engage with the communities we are working with. And I think your two examples are really excellent. I'm now going to move on to, I think this was mentioned by Nicole as a factor for success, and it's clearly in the publication. And we are moving to the partnerships, but to a very special type of partnership, the partnership with healthcare providers. We've seen this in several applications, and both Crecer and Development, you have very strong partnerships with hospitals, with clinics, with private doctors. So Vivian, can you tell us, how do you select these partners? And very important, how do you ensure that the quality of the services is good and that they are serving your vulnerable clients the way they need to be served?
Thank you, Gabriela. So partnership is a crucial portion of our program. There is much scarcity of affordable health providers in Bolivia, particularly in the rural areas. We work with any certified institution and professional, public or private, available in a particular region. And we sign collaboration agreements for 1 to 2 years, renewable upon review. Crecer offers to cover some costs, particularly transportation expenses, during campaigns in remote locations. And our requirements for the partnerships are the following: a willingness to offer service in specific days, locations sufficiently close to reduce travel and opportunity costs, discounted screening and treatment and other health issues to our clients, and a willingness to strengthen the capabilities of their staff to build trust and a warm disposition. And we work with 3 kinds of partners. First, regional centers that belong to the public health. The second group with private institutions that charge affordable fees for screening and treatment. And the third group are junior health professionals identified by Crecer to work together in campaigns for locations and communities where there is not easy access to public center. Crecer has a specific protocol to work with this group. Finally, Crecer has a tool to evaluate our 40 partners, which involves clients, loan officers, and brand managers. So this tool is an inside development, and it is working very well. Thank you, Gabriela.
Thank you, Vivian. And now, Nicolas, can you tell us about the partnerships you have in Thailand and Myanmar with hospitals and clinics and NGOs also, please?
Yes. So we work obviously in areas in Thailand where there are a lot of migrants. So we operate in 2 provinces along the Thai-Myanmar border and have replicated on the other side for border population and actually cross-border population. We also operate along the Thai-Cambodia border. So these are areas where there are a lot of migrants. And in Thailand, the problem is actually not the quality of healthcare services. Thailand has overall a strong healthcare system. The problem for unregistered migrants is a problem of access and financing. So in these areas where there are lots of needs, we need a buy-in from the public health authorities and the hospitals. And in those places where we've been able to work, there's a strong buy-in, and it represents, the M-Fund solution represents a win-win for also the healthcare system. So when there's a buy-in from the public sector, we can develop the project, and the quality of services is quite guaranteed with a strong healthcare infrastructures. Now, in some other places, we also work with private clinics, NGOs clinics, of course, and these provide good services and we trust them. So this is a good fit, but also with some private hospitals and clinics inside Myanmar. And we're also now replicating that in Cambodia. And there we evaluate the services available, the technical plateau, the cost of the services, and of course also the understanding by the provider of the philosophy of the project and the acceptance of its non-profit nature and need to collaborate fairly with us. So that's how we select these partners and operate.
Oh, great. Thank you very much, Nicolas. I now have a question from the three of you, and it's about the challenges. I mean, we cannot imagine that developing this program has posed a lot of challenges in the environments you are working. So maybe if you could tell us, what has been the hardest challenge and what have been the valuable lessons learned from those challenges? Nicolas, as I have you on the biggest screen, shall we start with you?
Yes, Gabriela. So, well, lately I would say that the COVID crisis has really been a great challenge for us. And it has been really the challenge of maintaining optimum activities and services in the midst of this COVID crisis, which has really affected very severely the migrant population and also for us represented a particular financial stress and commitment. But the situation is getting better and we've been able to go through this now. But since the very beginning, the key challenge really has been to find the right balance between maximizing coverage of healthcare benefits for our members. And again, we are non-profit insurance. So our intention is to maximize really coverage of healthcare services, both outpatient, inpatient, while at the same time working towards reaching financial sustainability of the M Fund. And that's not easy necessarily always to reconcile, but that has been at the center of the project, aligning those two. And we've made, I think, quite good progress in aligning those two objectives.
Yeah, and you've been evolving throughout the years, from the 1.0
Yes.
to the 4.0,
Right.
like to find,
Yes, we have adjusted our plan based on regular financial analysis and yes.
Great, thank you. Karin, what about Boutique Santé's challenges and lessons learned?
Okay, so our first big challenge is establishing stable supply lines. We work with we have a basket of around 50 products. 48% are local products, the other are imported, but we don't import ourselves. We buy from local importers or local producers. And COVID, difficulties accessing fuel, insecurity, earthquakes, it makes it really difficult for suppliers to maintain their supply lines. And so we regularly deal with stockouts. They actually have difficulties maintaining a product. And so that makes the chase and the clients very mad because they really like this specific product. And when we can't provide it, it's a setback for everybody. So we've learned that we need redundancy. We need 2 or 3 suppliers for one type of product so that if one has a stock out, we can actually find the product somewhere else, or we have an alternative product that can actually replace the one that's in stock out. That's the first problem we deal with. The other one is a little bit related also. It is that in the past years, there's been regular socioeconomic trouble and difficulties and insecurities on the road. And so we can have difficulties of getting through the southern exit of Port-au-Prince to the south. We can have difficulties of getting to one branch or to another because there are demonstrations in one area. The population isn't letting cars go by. So that demands a lot of flexibility from our drivers and from the dispatchers to find alternative roads when it's possible, or to be a little bit flexible. If they can't leave now, they'll leave in 3 hours. They've built information networks to find out about what the road condition is. So it's really about flexibility and making sure in the end we can supply the branch offices with products. We also keep a kind of a reserve inventory of products at the branch levels, and the branches exchange products amongst themselves so that we can actually cope with delays in the supply chain.
Thank you, Karin. Vivian, can you tell us a bit about CRECER challenges and lessons learned, please?
Sure. I will share the big challenges and how we deal with those problems. Most of our women and vulnerable women get a gynecological examination only at the time of delivery of their children. The CACO education and screening involve an intimate conversation and examination, so women are afraid and feel ashamed because their families do not openly talk about these topics. CRECER developed an innovative learning material for adults to introduce the CACO module, and it is careful. The training of loan officers, includes psychological and cultural dimensions. This is needed especially because most of the promoters are men. We also train the health professionals of partners to encourage a trustworthy and warm environment for women. We also include spaces in the village banking meeting where women share these positive experiences about visiting health centers or participating in the campaigns. So they can talk over the materials and encourage other women to overcome their fear and shame. The other one is that some of our staff, particularly the most recent hired, see CACU as an overwhelming technical task, which adds a major responsibility for the management of loan portfolio. The men also have fear and with these topics that they are not familiar. CRECER addresses this issue with intense training, using friendly methodology and providing a package of well-designed material with strong messages. Reaching CACU target is also a component of the loan officer's incentive system. Through time, all staff members became great supporters of the program, participating in the revision of materials and evaluation of providers. Currently, they have a positive appreciation of the intervention because it reinforces the loyalty of clients and it is in benefits also of the loan officers.
Thanks a lot, Vivian. And I had some other questions from you, but I see we have a question from one of our attendees in the chat. Amelia, she would love to know how the programs have iterated and adapted over time and what you have learned. We have 2 minutes. I think we are going to run a bit over time, but could you give a brief answer? And if needed, you can then meet Amelia during our networking opportunities or even exchange with her. But I don't know, who would like to take this question? The three of you can, but needs to be short answer. We cannot go over time a lot because there are more sessions coming afterwards. So please go ahead, whoever wants.
Okay.
Go ahead.
I can maybe answer quickly. We actually started testing, integrating health programming into microfinance since 2006. And we've tested like 3 or 4 different models before we found this boutique santé model, which is adapted from the living goods and BRAC model that they tested, they started in Uganda. So the idea is really you have to get a model, find ideas, and then test them and start over and over and over again. We started testing with a referral model where we would have staff that would refer clients to health institution and health services. And then we tested a model of prepaid health services. And then we started this kind of health micro-franchising initiative. So it really is important to test a number of models, see what works, and then scale up.
Thank you, Karin. Nicolas, Vivian, would you like to add something, share your experience, or as you wish?
Okay. Nicolas, do you have anything?
Yeah, very quickly, I would say that we have had to adjust our M-Fund plan, our policy, basically 4 times already. And we've done that. And again, this is to maximize coverage while reaching financial sustainability. And we've done those iterations based on real-time monitoring of key program indicators through the M-Fund application and microfinance analysis, micro-actuarial models by independent microinsurance experts. And each time we designed an adjustment, we had extensive exchange with our community workers who themselves consulted the community. And that's how we came about. We discussed with the partners as well, healthcare providers, and that's how we have made those iterations of the M-Fund plan.
Thanks a lot. Vivian, anything to add?
Yes, very briefly. Well, we try to adapt our program to give the same kind of program to the individual credits, which are not working in groups. So we have less time and we have another profile of clients. In this group, we are trying to adapt the materials and to make it shorter and try to give the clients, the women, a very brief information and education just in one session, because we just have contact with these clients once while they are having this loan product. So we are in the process to adapting these materials and product to the other kinds of clients and other kinds of technology of credit.
Thank you very much. I think we need to start closing, but for the closing, I'm going to take us here question, because it was actually the question, I was planning to ask you. Do you have any recommendations for MFIs or FSPs, on how they could use your experience to offer healthcare solutions to their clients and families? And here I would like the 3 of you, I know you have plenty of recommendations and ideas to give. So please take it in the order you want. You want to start, Karin?
Okay, so the first recommendation, as I said before, was to test models and keep persevering until you find a model that you can really use and that fits your need. I think that the second recommendation would be about metrics. It's maybe a bit difficult because Foncosé is this microfinance institution and non-profit institution. But if you want to incorporate health services in your microfinance services, you have to make sure you measure both the health outcome and the impact it has on your microfinance portfolio. So I think that's something you have to build into your model from the very beginning, so you can analyze both the impact on the 2 streams of effects you want to achieve. That's it for me.
Thank you. Nicolas, would you like to go next?
Yes, I could say, although we're not a microfinance institution at the start, but I think that what seems very important for us and for the question raised is here to really address a pressing health problem. I think in the example of Kaku and Cresser here, cervical cancer is really a major issue, obviously. So I think targeting a pressing healthcare need is very important. In our own project, we cover mother and child healthcare. We cover broadly healthcare, but that's a very large component of the services we cover. Mother and child healthcare services, chronic diseases also is a very important component. So trying to maximize really coverage and targeted pressing health need, I think, is really important.
Thank you very much. And Vivian, what would be your recommendation or your tips?
Our strong message is that microfinance finance can play a relevant role in addressing the client's healthcare needs. This was most frequently true in the early days, but it was abandoned as the institutions became regulated. Larger institutions like CRECER can leverage the resources, generating economies of scale and scope to implement comprehensive intervention, even though they operate under strict regulatory standards. A second important lesson is not to fall in the temptation to address too many health issues. Focalization matters, as a comprehensive intervention enhances impact. And our third suggestion is preventive interventions usually are most cost-effective for the client's institutions and society, and easier to integrate with financial services. Finally, as a lesson learned in other sectors, collaborative alliances share costs and sustainability to the interventions. Those are our recommendations.
Thank you very much. And thank you very much to the three of you. It's been really my pleasure to have you here today. I wish you the best of luck for tomorrow at the ceremony. And well, thank you to our audience for having stayed with us. Please join the ceremony tomorrow. Please join my colleagues' session tomorrow to learn more. Check the publication. Reach out to Karin, Nicolas, and Vivian on the networking opportunities. Learn more about their programs because they are excellent programs, and I'm very happy we had the chance to learn and to be with you today. Thank you all. Enjoy.
Bye-bye. Good luck, Nicole and Corinne.
Thank you very much.
Thank you.
Vivian.
Enjoy the
Thank you,
conference. It's been my
Goodbye.
pleasure. Thank you very much.
Thank you. Thank you
Thank
very
you.
much. Bye.
Thank you. Bye.
So that was a lot of food for thought. It's time maybe for a coffee or tea break. We'll see you in 15 minutes.